Just a second.
So, what I have discussed with Jen today is we have, I'm head of a laboratory in Brazil, and it's called the Interdisciplinary Laboratory for Research on Primary Care. Okay, and so what I decided to talk with Jen is not just telling you what we have been doing, but discussing how we have been thinking about doing it, because we have been discussing primary mental health care for 15 years now. The group, the research group, which is a group registered at the National Council for Research in Brazil, it started in 2002, okay? And so we started discussing, and things have been changing all over these 15 years. You know, some things that we did in the beginning, we no longer do, and things are changing. But anyway, why mental health? It's a laboratory for primary care, but why mental health? Why mental health in primary care? What do you think? Don't be shy, please. You know, I'm not very sweet, but okay, I'm trying to be more sweet in English than in Portuguese.
So why should mental health be incorporated into primary care? You know that.
Well, there's a high prevalence of mental health problems all over the world in every country. High income, low income, and primary care is the first stop that a patient goes to.
So access
to get medical care, and so it makes sense for them to be screened there.
What else? So high prevalence, need of access, easier access in primary care. What else?
Primary care can take care of some major basic mental health problems that don't need a specialist, so it's more cost effective and efficient.
Okay, major, what word did you use? The only thing I'm not gonna be so good
What did I say? Major
Cost efficient.
Cost efficient. Yeah, maybe cost efficient
for a minor
for
and moderate mental illness.
minor and moderate mental disorders. Could not use that. Okay. Alison, would you like to add something? Shan?
Sean, you take this one.
You can speak.
Well, access has been discussed. Prevalence, yeah. Well, look, I could flip it in the other direction, right? So the other way to think about it is, why is primary care really the best place, right? And the systems capacity that are needed to both identify and manage mental health conditions appropriately. And the tension within primary care between the original mission around medical services and now trying to incorporate and integrate mental health stresses a lot of systems. I know it's not the pro that you wanted, but it's a workforce issue, it's a time, it's a capacity issue.
It will also help diminish the demand on specialized systems.
Right.
Okay,
So back to the efficiency.
so going back to efficiency. Where's, it did not get?
I think you sent the same one again. We had 27 slots.
Yeah, that was it.
Oh, then it's it.
That's it,
Yeah, I got it.
All right. The other one has,
I mean, I know.
the title is this, that's the title.
Okay, then you good.
Go on.
Do you want me to advance so
Yes.
you can talk?
If it would
I'm
be
good
helpful.
for that.
Okay, so that's exactly what the problem is. That's why I did not need the slides. You already know it. You know, that's what makes me so good giving classes in this way, because people know the answers. You know, instead of get bored because I'm repeating things, we're just discussing them. So highly prevalent, but and also and another point that nobody said specifically, but the level of disability mental disorders bring. this is something very important. It did not used to be important last century, because we were dealing with mortality, but now that we don't deal so much with mortality and we are very much worried about the prevalence on disability because people are getting older also. So mental disorder is strongly associated with disability. When it comes to DAILIES, which is the WHO way of measuring disability, among the 10 most important disorders, 5 are mental health disorders. But also because of the lack of treatment, which is the mental health gap, which is greater in countries of the LAMIC countries, the low and middle income countries. So between 33% and 77% of the people do not get adequate treatment. And also, we still have very low expenditure on mental health. So, and then when we come back to Brazil, we have similar numbers. 20% of the Brazilian population have emotional disorders, which include common mental disorders, which are anxiety and depression, depressive disorders. And mental disorders represent 27.8% of the DAILIES, which is the disability level, which is 1/4 around, no? And what we found is that since the 80s, and the numbers haven't changed, unfortunately, between 50 to 60% of the people attending primary care units have significant emotional distress. So it's not only a problem, and I think this is an important thing for us to have in mind, it's not a problem that primary care should take care of patients instead of specialized care. The real situation is people with mental disorders are already in primary care. I think that's the difference, because in one of my first papers I used to say like that, it's good for primary care to take the place of specialized care. Nowadays what we find out is that people don't go to specialized care. That's why the gap is so big, but people are in primary care. So it's easy to get them there. 40% go on.
I was just wondering, when you're talking about specialized care, are you talking about specialized mental health care or other specialized?
No, specialized mental health care. So community mental health cares, outpatient with units, services with psychiatrists and psychologists and all that. Okay, let's go. So, first of all, highly prevalent. You have said that. And there is something we have to learn, which is family doctors and primary care professionals, they are specialists in highly prevalent disorders. That's one definition of primary care specialists, family doctors. On what are they specialized? They are specialized in prevalent disorders, So, especially anxiety and depression. They are disabling and should be treated as soon as possible. Primary care is very accessible. They are and this is an important aspect. Mental disorders are very stigmatizing, and people don't like to go to specialists, psychiatrists. If you go to a psychiatrist, you are stigmatized. But in primary care, they are very inclusive. Go on, John. Then, this is another important aspect. If you have somebody with a physical disorder like diabetes, and you have a mental disorder, the prognosis gets much worse. So getting them to be treated together will not only increase the mental health of people, but also physical health. So you have to treat people in a comprehensive model, And then, I love that, mental disorders are too important to be left to specialists. This is not my sentence, it's a teacher I had, Mental disorders are too important to be left to the psychiatrists. He was a psychiatrist. So, and primary care is interdisciplinary, and we expect them to solve 80% of all types of health problems. That includes mental disorders. So what we are talking about is task shifting.
So can I just go back to
go
the
on.
mental disorders that are too important to be left just to the specialists? Because there's no way that you could have enough specialists to deal with. So is it around quality or quantity? It's around too much demand for specialists to be able to attend appropriately to the need? Or is there an expectation that there's a difference in quality?
This is a good question. This is an important one. We don't need specialists for all types of mental disorders. That's the point. We should not keep on with the last century model of is isolating mental disorder treatment. They should include it.
I think part of it, I didn't think of it this way, but I'm really not glad that you put it this way, because we have been taking, anytime anyone says depression, anxiety, they go to a specialist. But every time anyone comes in with the flu, we don't send them to, with pneumonia, we don't send them to a respiratory doctor. Somebody comes in with a stomach. Right, so 80% of everything is handled in primary care, they should also handle the easy 80% of the mental disorders. I think that makes perfect sense.
That's a huge, because we keep on saying, so we are putting them in the place of specialists because we don't have many specialists. No, that's not wrong. It should be done, it should be held by primary care because they are highly prevalent and they interact with diabetes, hypertension. So no way to separate. That's why the title was No Health Without Mental Health. And if you ask a good family doctor, how many consultations on mental health do you have? Which would be his right answer?
All of them.
All of them. Exactly. Yeah. Okay, go on. You.
Well, I mean, sort of just two thoughts. One is around bringing in. I mean, is it in one sense it's moving mental health care into primary care settings, but I come from a HIV specialty background where the idea of integrating mental health into the HIV specialty field is sort of the model, right? So just thinking about the extent to which, if you think of specialists, not only as mental health specialists, but other kinds of specialists, which I know depends on where you're living and what you have access to, but to what extent does one have to think about trying to bring mental health specialists into other specialties, as a kind of integrated model, not only towards the sort of primary care
There are
model.
two ways of building integrated models. All of them both include interdisciplinary teams. But when you have a very high specialized professional here, like for instance an oncologist, he will need a psychologist to deal with the emotional aspects of having cancer or being terminal. I don't know if you have that word. And so this is one way of being integrated. But when you're dealing with primary care, and we're going to talk about that in a little, they are more person-centered primary care professionals than disease-centered. And so they can handle mental health by themselves.
Okay.
So the connection is different.
Yeah.
In both you have interdisciplinary teams, but the type of work is different because here you have a specialist plus another specialist plus another specialist. And here you have a specialized group working with a general practitioner or a general or primary care nurse. Go on.
Sorry,
Let's move just a little.
You want to
can,
okay.
Yeah. Go on. Go on. What you were going to ask?
So it's going to pick up on it, Abigail's point and turn it a little bit. So we have primary care specialists doing lots of things that they didn't used to do, right? So in Brazil, as in the US, we now have them managing almost, they manage HIV, which is not what they used to do 20 years ago, right? So we've given them, now they have HIV, right? And a chronic condition, and not easy, right? And so now we're saying, playing devil's advocate, okay, you got that. Now let me give you something more. Here's depression. Oh wait, you got depression. Here's anxiety. At what place?
Go back.
What place does the plate get too full?
Back.
I'm trying.
Okay.
What place does the plate get too full? And we're just expecting too much of primary care.
One more. They are too filled already, but people are already there. That's the difference. Okay.
The patients are already
The
in.
patients are already there. 40%. You can go on.
Okay.
40% of the patients sitting at the waiting room for hypertension, or anything else, including HIV, they have mental disorders.
So you're saying it's a workforce and capacity issue?
It's just, they're there, and if you don't treat them, they're not gonna get better from the physical aspect. One important thing was in 1988, with the new constitution after the dictatorship ended, the health system in Brazil became a universal free system. And that means when Jen goes there, if she has an emergency, which for sure she won't have, she's gonna be taken to a Brazilian hospital, an emergency ward, and nobody's gonna charge her anything. Okay? Yeah. They're gonna have difficult understanding English, but anyway. And so it's 20 million people with different realities, and the system is county-based. So it's 5,520 counties, and each has sort of certain autonomy. I'm talking about that because what I'm gonna talk about is what is happening in Rio. Some areas of the country is not gonna be the same, but Rio is considered one of the best, okay? 1/3 of the population also have a private insurance system, but they don't lose what is called the SUS, the general health system, okay? Then, so what was done 23 years ago was start a new primary care system with the family-based strategy, and that team is a team with a nurse, a family doctor. Not all of the doctors are family doctors, only a small amount of them, a nurse technician, and 6 community workers. Okay, it's not based on patients, it's based on family and territory. So it's an area, usually a slum. So with between 3,050 and 5,000 people. And they do everything, which is something we have been discussing. Public health is not only health promotion and disease prevention. It's also diagnosis, treatment, and rehabilitation. So they are connected with everything, okay? All levels of activities, go on. So here you have the territory, and then you have the team, and they provide comprehensive primary care support. So it is supposed to include everything, including mental health approach. Not only mental disorders, but also emotional distress. And they have the support of auxiliary teams, including psychologists, psychiatrists, and other specialists, which are the matrix supporters, talk and working in a new model called collaborative care. So this integration with the matrix support teams, so each support team takes care of 9 family health teams. So each support team with 1 psychologist and 1 psychiatrist. When you manage to get the psychiatrist, we don't have that much psychiatrists. We take care of about 35,000 people. No? This is a worldwide discussion with several new models. The United States has one collaborative care that came out of the University of Washington, Caton and Hughes, and of course shared care in Canada, Nick Cates and others. But we have our own, which is the matrix support, and the TACT. It's not to and this is something very important. I was discussing that with Pajo in Panama, and the people said, "Oh, they detected more. We got more referral." For us, this is not a good indicator. We don't need more referral. We need more solution in primary care, and that's what the point. So the specialists came to help define the primary care teams. Go on. So that's how it works. You have the family health teams and the matrix support. You have women health specialists, you have children health specialists, and you have mental health specialists. Okay, which are you can go on, psychologists, psychiatrists, social assistant, and occupational therapists mostly. No? So you have to, the purpose is to exchange knowledge, strengthen patient-centered medicine and not disease-centered medicine, develop new projects, mental health promotion and prevention, collaborative care, which is held through case discussion, joint consultations, and interdisciplinary actions. This is the core of matrix support. It's a different way of working. I don't send my patient to Jen, who is a psychologist, and she treats him. I see the patient. If I don't know how to solve, I'll call Jen, and she will come. I will discuss it with me, see the patient, and we are going to develop the treatment plan. Maybe that plan includes going to a specialist referral, but some of them are to be held inside the primary care unit. Okay. Of course, she teaches me, and I also teach her. And we developed new interventions, which was something she asked me about, the psychosocial interventions. You know, what can we be done in primary care? And of course, support the teams, care for families in a vulnerable, and organize an integrated mental health network. Go on. There is one thing is changing. Health system used to be drawn like a pyramid. You agree? I think it's better as a net. You know, so you had community, primary care, secondary care, third level care, so like a pyramid. In reality, it's a net. If that net does not connect, the system does not work.
So just wondering with the family health strategy of those, are there physical like locations? Those
Yes,
are
yes,
community
yes,
health,
yes.
And then is there
The
sort of-
matrix support teams have no units. They have no service. They go around. But the service, the primary care, the family strategy, yes, usually close to the poor areas of the country. Now we have 40,000 teams.
Okay.
So that covers 160 million people because it's around 4,000.
So in the clinics that Sean and I visited, how many family health teams would be in that one?
In the one that you went for, also for the party, yeah, that has 3 teams. That whole community you saw, 10,000 people.
Okay.
Very poor community, very, very poor community. Okay, so what does research does? Research people have questions which develop into aims, objectives. And then you have a methodology to study that. That's simple, very simple. Doing research is simple. Get a good question, draw a good objective, and find the right methodology. We had 3 questions. Very simple one. Which were the mental health problems in primary care? Second, what solutions may exist in primary care and how would they be implemented? Okay, so the research, we did a lot of research defining problems and finding, there is a tool here that it should not be here, it should be number 2. Develop solutions. We need to train people in the new intervention and implement solutions. If these solutions work, we train them and we implement them. So 4 levels of research. Okay, so now, okay, what research would you do? Great, would you have done? How can I erase this wonderful,
I got you.
I love that. Did you take a picture?
Yeah.
Oops, Brazil falling.
Why, you know, it's like feeling being a kid, like you like to draw on the wall. Go on, what type of research would you do in this situation? Remember, you were 12, 15 years ago, we were starting.
I mean, so you're trying to find out which mental health problems were prevalent in the primary care settings, right?
Yes, well, that was the first one.
Mm-hmm.
That's what is the problem? Which is the problem? So, prevalence. So, the first studies we did were prevalence studies. There were some, but not in the new system. What type of methodology would you use for a prevalence study? Surveys. That's what we did. So
What
we did
about
not
medical
do.
record data collection?
Huh?
What about medical record data collection?
Well, medical record collection will not give you prevalence, it will give you detection. Yes, because if the doctors did not detect, that would be not close to the prevalence, and that's what's happening. Sean and I were discussing alcohol in this unit. They have visited in front of a big slum with a great summer school, 10,000 people. We went now, last year, through the records, not one ICD registration, because we do not use the SM, we use ICD. Not one registers one case of alcohol disorder.
Wow, it's a miracle.
Yes, they're all religious people.
You're all
that don't
teetotalers,
drink.
yeah.
And that's not only in our area. The guy that is now responsible for primary care in Rio, he loved the idea of the study because his master did the same thing, and in an area, I don't know how many times larger, he got 140 cases
With alcohol problems. Wow.
So survey, that's why we did not go to the records. So in this situation, studying records, which is a good thing, would mean studying, we call it effectivity or efficacy.
No, it wouldn't be effectiveness. No, it's just detection.
Detection.
But for you, it's just
Anyway,
administrative record keeping because it's not accurate. You don't get anything from
Well,
it.
it provides an accurate
Yes.
sense
Again,
of what
it-
they
it-
are
it-
serving
yo,
as before
look,
you're serving
it
the
provides an accurate information that they are not treating this.
Right.
They're not
That's it.
identifying
When
them.
it's
They're
so
not
low.
identifying, if they identify, they are not registering. If they are not white, if they identify, they do not register because they do not treat. They don't register because they do not treat. If you register, you're supposed to treat. If you don't know how to treat, you don't register.
You don't
Okay.
even ask the question.
They don't ask the questions.
So,
Okay, what else?
Even the one where they found 140 cases, that's just 0.5% of the population.
In that area,
Yeah.
that's a much bigger slump.
But
The one-
even then,
the one
it's
you
just 0.5%.
That's nothing. We're not finding, we found that they are not treating it. That's why it's so important to do the alcohol study.
Yeah.
Go on. So what else? When you come to prevalence, one good aspect would be associated factors. What about that? Who are the most vulnerable? Groups. Who should be our priority? Should we go treat men or should we go and treat teenagers? Should we go and who are the most, at least in primary care, because look, we're not working in the community, we are working inside the primary care units. So even if the problem in the community is one, but if the most important problem in the primary care is another one, we have to start by the one in primary care. Because that's what we remember always. Questions, aims, objective. So what are you gonna do? Science is not building a new building. No, it's more or less like putting a small, what do you call brick?
Block.
Or brick or block. And some very, very brilliant people, they open new windows. But usually what you do is just put small blocks.
Out of our kids.
Yeah. What else?
So, just so I can follow, so you collect the prevalence rates through a survey and then you stratify it by demographic variables to know what population you
Yeah.
want to target an intervention to,
Yes.
which I think would be a next step, but
Yes.
I don't know if this is the norm, but maybe doing a qualitative study with a group of people at the clinic and knowing what they would, maybe hearing their perspectives on what they would like to see.
Good. So, qualitative, we did that in another moment. Qualitative studies on personal. What does gives us information about
So,
their demands?
yes. So
What do they need? What do they feel they don't know? Which is not necessarily what's not being treated. So this is another perspective. And we did use that exactly on that idea. But what you get here is your demand. Look, it doesn't matter. It's just get the right question and try to find out what you're studying. It's only your block. Okay, what else?
what about building on what Evelyn said, qualitative studies with the provider?
No, personal, providers.
Providers.
Sorry. Yeah, that's it.
Personnel.
That's the idea. So
Okay,
see what's their demands are. Okay? We did use that in another moment.
But
What else?
you also.
If we find a special population here, we did find women, poor, illiterate, no marriage,
No
no
job.
job, anxious depression problems. That's what we found. So the second paper was, this is the priority. That's what we found. So what should we do?
Do an intervention that targets that.
Great! I mean, can you send some of your students to Brazil? I need them. And I'm very glad that you invited me, but I don't think you really need me here.
Yeah,
Where I will be.
Right. No, it's in go, yeah. Abigail was saying, did you notice Jen's just invited everyone to join you on your Fulbright, Sean?
Good shot.
Yeah.
Okay, get the information.
Can I just ask, prior to that step, were you looking at the literature at all when you look at your associative factors? Is it mainly from your primary data you're collecting through the survey, or just wondering
Well,
if
we
you're
have
looking
literature on that. We have literature since the 80s,
right?
but
Does that have a role to play?
the system changed, and we wanted to know the prevalence among that special system. You know, among that.
Oh.
In each team, what is the size of the problem in each team?
I see.
Okay.
Specific. to
Yeah.
The infrastructure, I think, was quite different, where they didn't have the same infrastructure, certainly not in the 80s, of the kinds of national
Universal
surveys that we
healthcare.
have here in the US.
Mhm.
And so they're essentially creating all of that infrastructure by
But
doing
we-
all of this work.
Yeah, well, the point
I
is,
see
we
the
had
surveillance.
Yeah.
the prevalence of common mental disorder has been the same all over since the 80s, but we did not have the structure. So we did not have any idea about what was the size of the problem within a unit. You know, because like when we come to alcohol, some studies show 10% of abuse in a Rio area, not one patient in the waiting room. So you have to have a different solution. But all these women were in the waiting room, all of them. Okay? So, one intervention. What type of intervention? Go to the literature. We tried what now is a model for WHO, which is called Problem Management Plus. Okay? But this deserves treatment. If you have somebody, if we have over 50% of emotional distress, okay, in the waiting room, 40% already have the anxiety and depression disorders, but they are not, most of them are mild level, some are moderate, some will need medication and all that. But you also have to do something that those 15% that have not yet met the criteria for disorder, they become disorder. You understand? Because the level of emotional distress includes mental, anxious and depressive disorders, but they also include what we call emotional distress, emotional suffering, which does not fulfill criteria for a disorder,
So you wanna identify
For
those
pre.
but they are at risk.
at risk.
Yes, we don't want to identify, we want to address, so we also have to develop mental health promotion and prevention.
That's right, because when we were putting the proposal together, Sandra, we proposed to do surveys of women in the community. And we were looking at what proportion of them will be meeting clinical criteria, what proportion of them will be at risk. Basically, those two numbers added to 100%. Because if you're not depressed now, you're at high risk. Just because of
The
you're
context
poor,
within the
you're living in
prevalence.
this community, there's a lot of violence, there's a lot of drugs, there's a lot of other things. So that's a different model than we have here, where at least theoretically, there are those of us who are not either depressed or at risk for depression. There's a group of us that's not at risk for depression. You can see how this can move though. It depends on how you view it. You could view everyone who's not depressed as at risk.
And if we're gonna get the intervention, who's going to get the intervention?
Sandra, that's why when you're doing the interviews with the personnel, with your workforce, are you matching workforce training with the identified need in the community?
Yeah, that's the point. Okay, what we found out is that they don't know, so we had to train them. So we have to do training, and we have to evaluate training.
So you train them in the management, the problem management strategy from who?
We train them in detection and treatment,
Okay.
okay? And then we evaluated it quantitative,
Mm-hmm.
but we also evaluated how they felt with the treating patients with mental disorders. What type of training did they enjoy? What type of intervention they did enjoy? How did they enjoy the intervention? Because we also train them for the interventions, mental health psychosocial interventions, not only medication, not only detection, psychosocial. No? And so this was qualitative. And that's where the study qualitative came in here, okay, with the doctors and nurses, but not only with the training for the interventions and for detection, but because here, what came in was matrix support. Matrix support started in 2008. Okay, we started the research in 2002. In 2008, they started, and we did the intervention included detection, treatment, psychosocial interventions, and joint work, collaborative care with matrix support. And so we also evaluated that. Okay, both qualitative and quantitative. That's finished.
Sandra, yeah, we've got about 5 minutes.
I know.
Thanks, Hans.
So, now the problem, epidemiological studies, we also did specific ones connecting to quality of our life. So we used a subjective indicator, not only a diagnosis. And also, this was very important, protection and risk factors. That's why after protection studies, we went on with psychosocial interventions. They were collected. Because people talked about group support, family, friends, all that. So we thought that would work. And we came out with a very interesting aspect of stigma, which is obesity. Obesity is a stigma in Brazil. You know, very well known for the way people are very much worried about their approach. And so these were results that I already talked about. And look, only 17% treated correctly in the best centers. In the worst centers, 4.6. And then another problem came out, the inadequate use of benzodiazepines, which is now connecting to another intervention. Go on.
So, Sandra, Alison, can you go back just quickly? So the lack of treatment, right? So that's the percentage treated, right?
17%.
Sure. What do you know the outcomes of the treatment?
We only registered treatment.
Okay.
We know that it was not well done. We don't look for the outcome because it was not correctly done. We
Okay.
had a lot of benzodiazepines, and one indicator of better was when people started treating with antidepressants.
So this is the paper this is from the paper that we worked on?
Now, this is from another thesis, but it came back again in our paper because
Right.
with the matrix support,
Right.
that changed it.
Right.
It
Right.
increased.
So the 17% means that they were identified as having some problem,
And
so
they got-
detection.
Right.
And they got
Something.
anything.
Yep.
And what
Yeah,
Sarah's
yeah,
saying
yeah.
is that a lot of those people who got treatment, which is ostensibly good, got the wrong treatment. So they got benzodiazepines when they should start
Yeah.
getting tested.
depending on the center. The study you are talking about, we're gonna say in a moment. Go on. And so here, development of solutions. So there are two things we should do. One thing is what is already done in literature, so the study from Chile came out. And also, we have one thing that I learned that it's not called extension, which is service. So this is something the laboratory does also, which is working with the community, with the county, the mayor, the health department.
Like what we do with the health department, so we're with the university and we're reaching out.
So
we think of
in-service
research
training.
teaching
In servicing interventions.
Interventions.
Okay, and so we did with the Red Cross, an intervention for violence, people that were victims of community violence, and interpersonal therapy, and also study the matrix supporting. We started doing it. And then one good thing was we looked for what people were already doing. Because people, when they are there, they have to invent something, otherwise they're gonna get crazy for not doing. And the university sometimes considered that, that's not research, that's not evidence-based, and blah, blah, blah. And so we said, let's go, and then we started as an in-service research to study the handcraft groups with women. And we did qualitative studies and implementation. It was the first implementation using the SWOT, and we got a prize on the National Conference of Women's Health. We were one of the 6 best interventions done in Brazil.
This is working with groups of women to make handicrafts, and they can talk about issues while they're there, and then they're producing something, and also keeps them safe from the violence in the community.
And so now we are very much worried about other types of psychosocial interventions because they are very effective, and in Brazil groups are very effective because this is part of the culture. We have a collective culture. So,
No, it's so funny because in the US, groups do not have a good reputation.
Well, yeah, when we talked in UK about community therapy, which are
Substance abuse.
mental health promotion, and we showed the movies. I showed you the movie, and people hugged each other, and people sang songs together. You should have seen the faces of the British. I mean, it was like, what's going on here? But anyway, we're Brazilian, and then so that's it. And this studies on IPT comes from Africa, and it was spread, but it was not evaluated. I had problems with the Red Cross to evaluate. Very, very difficult issues go on. But anyway, they're International Committee of Red Cross. They're all heroes. They're all getting inside places where nobody else did. And the study she was talking about is this study. We sent it to publishment, which is comparing primary care, traditional primary care with metric support. After 1 year of metric support, we had 150 patients positive for screening in both groups. Go on. And what's the criteria? And so this is the criteria: access, effective, good quality, and longitudinality. These are the indicators we could use. We use access. Okay, which was the first one, because you're not effective. If you don't have access, you're not effective, you have low quality, and so on.
Yeah, you gotta get in the door before.
Yeah, go on. So, what happened, the results was detection was increased, access, contact with mental health specialists in the joint consultation was increased, referral reduced, and quality of psychopharmacological treatment increased. Okay, and we did not have any psychosocial interventions done. Okay, so that was the result. We compared the two teams, traditional one, 150 patients, and that's the paper.
So
And
just
finally,
quickly, I'm
yeah.
sorry. The referrals decreased because they were
Refers
feeling.
to specialists.
To specialists.
Right. Because they were dealing with it inside, or they saw it, or was it because they were seeing less severe patients?
No, it's because the specialist was in there.
That's probably good.
Because
Thank
they
you.
got contact, the contact with specialists increased. That's the one good point of
But
the
it was
matrix
inside
report.
already. Okay.
The contact with the specialist increased. But what you find out is that you don't need the specialist so much.
Good.
Like if you have a very severe mental health patient, but he has obesity, he smokes, he has lung problems, he has hypertension, he has diabetes. What is the good of taking him out of primary care and putting him in a community mental health center? You know, he's gonna be fine with his head, but he's gonna die. So that's what happens. They die 10 years before. They have less 10 years of life, okay? And so we train the people, and which is, evaluate training is difficult. That's why quality studies are so important, because evaluating skills, knowledge, and attitude is very difficult. Very, very difficult. You know what happened here? We did this study, we returned 1 year later, we trained the people, and the nurses increased, and the doctor's quality detection decreased. You know what's happening? When we went back, it was in the middle of an HINI epidemic. People were being attended with the protection.
Yeah, the masks.
Yeah, and we learned one important thing. When you don't have good working conditions, mental health is the first thing that it's left behind. The epidemic was very hard because I had it. Okay, and now I always have them. I did not have dengue, but I had dengue. I always have them all in the first epidemic, in the first episode, you know. And now we have a project for e-learning just to finish. And so now we did the one study on implemented solutions, study on the headcraft groups using the SWOT. And that's what I'm here to learn with you all. Because we are starting mindfulness study, Medita SUS, where we're getting mindfulness all over the country. And we're starting with a pilot with about 130 professionals. We're supposed to get 1,000 professionals in 5 cities, in 5 regions. I mean, we're not afraid of numbers.
No, that's good. Training 1,000 professionals in mindfulness meditation.
No, for them to, not only for them, but to lead groups in primary care.
So it's a training of trainers.
Yeah, a train of trainers.
Great.
And then the mental health gap intervention guide. That's what I was telling you that we should do. And here's the project, Primary Mental Health Care of Cuni and Voyage. And I think that's the end. So Jennifer going on, helping us with anxiety and depression, and Shen with alcohol.
With alcohol identification and treatment, just to be clear.
You got the better end of the end.
But, that's the last one, but, for that to happen, mental health care needs to become a priority. We cannot have such a little budget. Second, it needs to be understood as part of primary care and by psychosocial program. It must be supported with funding, and it must be interdisciplinary, and it must be culturally competent. Okay? Thank you so much. Sorry about the problems with the slides, but it's 5 minutes delay. That was good.
Great job, great job. So, just a couple of quick questions for you here. For y'all here, how are the challenges that Sandra described similar to the things we're working on in Pride? What are some of the things that are similar? Anybody?
I think a big one is always going to be funding.
Yes, funding. What else?
The integration.
All over.
The integration of behavioral health, mental health care into primary care settings.
Right.
Still a challenge.
Right, and the scope of really trying to change whole systems of care, right? What else?
Data.
Data, how?
Well, they have electronic health records that cover families nested, individuals nested within families nested within neighborhoods.
Right, the challenging data stuff, and ours is, we have a baby and a mother on totally different medical
Right.
records and they're not connected. So the exact opposite problem, but we
Can
still
I say
have problems with
something?
data. Yes, ma'am.
Funding is not the biggest one. The biggest one is one national health system.
Well, I was getting to the places where we're different. A place where we're the same, as you mentioned,
Yeah.
you wanted more funding for mental health. I
Yeah,
think
yeah, that's what.
Yeah, there's also a difference, or a similar, where there's cultural differences in how primary, I would say, cultural differences between primary care and mental health, as you mentioned, that we're still trying to get those things together. And then Sandra's working at a university with clinics and with the government. And so we also have that in common where she has multiple stakeholders who are trying to move things forward.
Yeah.
So now how are we different? Number one is she has one healthcare system, not 45 like we do. How else are things different?
Big area for us.
How else are things different?
I mean, I don't even really know the full extent of mental health in primary care here. It sounds like it's further along
Uh-huh.
in Rio than it is here. I mean, granted,
Yeah.
I haven't been to primary
No,
care
that's
in a while.
If you can back up to the slide that showed all of the little hexagons, they're building on a system, a primary care system that is so much more organized than ours.
I mean, it
So-
sort of stems from that nationalized
Exactly.
problem.
Exactly,
We
because
don't-
the funding
our
helps
system
keep
is
it
so
structured.
fragmented.
And did you all, and Sandra made this point, but having been there, I think, but understanding, that given that structure, right? So, Sandra, can I?
Go on.
So
Let me
look,
get out of here.
no, you stay there, but look, this is the entire health center, right?
A clinic.
No, this is the,
Yeah, right? This is.
no, this is different areas.
Oh, right, but
This is one area.
so this health center serves just that
Yeah.
area?
No.
All of these teams?
No, so, yeah, this
Right?
is one health
That's right.
center.
Yeah.
Yeah, sure.
So look,
Sorry.
that's one health center with all those teams, right, that might serve an area like this. And each one of those teams has a designated area that's geographically defined. And within that geographic definition, each community health worker has about 150 families.
Right.
And so each individual is nested within the family, within this little bitty geographic area overseen, or that is the responsibility of this community health worker. The ability for that system to integrate public health and primary care is almost endless because it's one, universal, two, there is not only responsibility for the health of the community, there's accountability. So they have charts of each community health worker, and the face of the community health worker is there. And we've seen this with each household here, right? The name or the address, the name plus the address, and the date of the last visit, and the outstanding issues that still need to be addressed for every single household.
And every community health worker visits every family how often?
So
You're
once a
supposed
month,
to visit once a month. We discussed that. We really questioned that.
yeah,
because-
think?
Yeah, because look, I have a community worker myself. My house is in an area where I have a community. I have a private insurance, okay? But anyway, I live with my son, 24-year-old. We don't have any health problems. We do not need a visit once a month. But the system was designed for poor areas. They are reaching. Nowadays in Rio, we have 70% coverage, 70, and 1/3 to 40% of the people have private insurance. So now we are getting in a mixed area of people that in reality, the things are getting worse because the people with private insurance are losing the insurance because of unemployment, losing jobs.
So we could see how, I think Sean, that was perfect to describe how there's already that sense of accountability for every individual family within the region. And that is something we don't have at all.
Right. So
And
we
in
have
fact,
a responsibility, we feel responsible.
Yeah,
or
we
not.
have that.
Or
we have
not, if they
that-
don't have insurance,
Wait.
but this is both the responsibility and the
But
accountability.
there's also the responsibility around the follow-up. So for
Yes.
example, in the maternal depression project, once the woman gives birth, her depression is no longer the gynecologist's responsibility, it's the responsibility of the next doctor who may be at a different office or somewhere else. Here, everything is viewed together. And so that makes a huge difference for not only how public health and primary care services are provided, but the capacity, as Sean said, to integrate mental health. You've already got an amazing system. we are trying to put mental health on top of this patchwork crazy quilt of insanity and trying to get this doctor at this clinic and this doctor at this clinic and this doctor at this clinic to work with totally 25 different psychologists each. That's a very different system.
And do you know, very funny thing, you know, one author that is one of the main reference for the Brazilian system in America?
Yeah.
Barbara
Starfield, of course, that's what
Yeah.
we used for
Yeah,
the
and then-
recruitment study.
And then the 4 principles
Yep.
of the Brazilian system come from
Compare, yeah,
which is
1992.
Iowa?
80% resolution of 80% of the problems.
Yep.
Family and comprehensive approach, patient. Person.
USA.
You have good things besides Jennifer and Sasha. And longitudinality, I mean, that's the point. We have now people that are taking care. The system started in 94. We have doctors that are taking care of the children.
Right.
They took care.
That's a problem, yeah.
That's good.
Problem here, yeah,
Yeah,
that's
but
very
that's
good.
very good there. And also, what we call there is a term for that, which is sanitary responsibility. It doesn't matter if he goes to the specialist, it still belongs to primary care. And they look, if he has renal insufficiency, and he has to go 3 times a week for a dialysis, of course it's not going to be done in the primary care, but the primary care have to know if he's going. They will work with the family about the food. They will call a nutrition to go talk to the family in there, which is different from doing that inside the hospital.
I'd say one more difference is something that we've all encountered, which is Sean was talking about what gets posted. It is posted what proportion of the community has a particular chronic disease, and then whether it's being taken care of according
Right,
to
how well it's managed.
yeah, how well it's managed. So, 40% have diabetes, and of those, 90% are being managed appropriately.
Have controlled A1C levels.
Yeah.
And it's
Posted
on
in
a
the
whiteboard as you walk into, this is a reception area, that's the
Right.
whiteboard.
Everyone can see it.
All the
Patient
major
and everything.
disorders, all from leprosy to diabetes to hypertension to which trimester a woman is getting maternal child health care,
that you don't
all there.
Is that
We have
updated every day?
tuberculosis.
I think every month.
We have a lot of
Monthly.
tuberculosis. We still have a lot of tuberculosis.
Right.
And hence,
Pretty cool.
the tuberculosis patients in the first 2 months of treatment, the community worker takes the medication to the house. And the person has to take the medication in front of him.
Absolutely. The Partners in Health model.
I mean,
right?
And I
DOT
have
here,
used
it's not-
that
We do it
for
DOT
mental
too.
disorder. Just one
I mean,
last
those
funny
kinds of-
story.
they're not organized
I
in
had
sense.
this because the most important thing in Brazil, and they know that, is that
Never told
life is
you.
hard, but it's worth living and funny.
Yes.
Okay, so I had this family
Yeah.
that the woman came to me in a joint consultation with the doctor, sent by the dentist. Yeah, so the dentist she said to the dentist that she had lots of worms in her dents and he couldn't see anything. So he
Works
found
on
out,
teeth.
yeah,
Yeah.
worms coming out of it, there was nothing
Yeah,
in there.
yeah.
He thought she's psychotic. He sent it to the family doctor saying she's psychotic, get the psychiatrist. He talked to the woman, confirmed that, called me, she had a psychotic depression. Well, she lived in a house with a demented mother and a schizophrenic son. And they all had psychiatric medications. We started the antidepressant, antipsychotic. 2 weeks later, what we found out, or 1 month later, they all were taking the medications, not the adequate one. So we had, because the only person that could take care of people were one that had a psychotic
Right.
depression.
Yeah.
And so we got the community worker to go there for 1 month, every day, and we gave them plastic, small,
Yeah.
with the
Yeah,
divisions.
the pill boxes.
The pill boxes, organized the medications until the women got to be right. And then we managed to get the boy, which was about 20 years old, to a community mental health center because he needed it, and the demented mother was better cared, and then 2 months later, everything was fine. but the community worker was precious. If you did not have him, you know, if they had gone to different specialists, it's not gonna work.
So the
And the
flexibility of
family model, I
Yes.
think, you know, you don't see each
Household.
person as an individual,
Yeah.
right, the household level. Seems-
Sorry about the problem with the slides, but I think it was enough.
Yes.
Get the message.
It's good. Thank you so much, Sandra. It's a real pleasure. So
Yeah,
Sandra
so
will be
we'll be
talking
here
about some similar work but different on Wednesdays.
Great.
Please plan to come to Grand Rounds.
And it's not gonna be so fun because it's not gonna be so participative.